Okay, airway assessment. Okay, in the class we teach lemon. Okay, and I'm going to teach heaven too. Okay, we teach lemon because you're going to find lemon on the exams. Okay, it's something that was designed for the OR. Okay, this is designed for the OR, for anesthesiologists, CRNAs, in a nice controlled environment, not in a crash environment on the side of the road or in a field type setting. This is not what it was designed for. But it's still on the exam, so this is why we teach it. But we also teach the heaven next, which is more clinically applicable to what we do in our setting. But we have look externally. So looking outside, okay, what does my neck look like? Are they kyphotic? Okay, are they hunched over? Do I not have movement? Okay, what's in the way there? Evaluate their 3, 3, and 2, okay? That's going to tell you if they have an anterior airway. So we're looking to see, hey, if they have an anterior airway, okay, it's going to be probably a little bit more difficult to get that intubation than just your standard adult or pediatric. The Mallampati Scale, this is something that, you know, clinically, this is, if anybody's going on the OR or had any surgery done, what do they have you do? Stick your tongue out, right? And they're looking beforehand. Okay, how many patients do you guys run into if we're getting ready to intubate are able to go, yeah, exactly. No, they're not able to do that very well. Okay, so this is something that we typically, and I have to document this on my charting, but guess what I have to do? I find this out as I'm in there, really. It's like, hey, what do I get when I get in there with my blade? Okay, is it a grade 1 or is it a grade 4? Most of my patients are either going to be a 1 or a 2 or they're going to be a 4. There's like no sweet spot in the middle, okay? And this is where the bougie video laryngoscope, some of those adjuncts head up, okay? How many people intubate supine? We've been taught for years doing it. Ronnie and Joy did, or Johnny and Roy did, right? We don't do that. I don't clinically intubate anybody supine unless I absolutely have to or they're stuck on a backboard. Even the backboard I will tilt up. Because if you ramp them up, and we'll talk about the ear-to-sternal notch position, if I ramp them up, okay, it's going to line things up. I'm going to have a better chance at success. And your best chance is your first attempt. So it goes back to that preparation and planning. Get all your equipment out. Go through your checklist. How many people here use a checklist real quick? Okay, not that many, okay? It's a new thing that's coming out, but once again, it's another very small thing. You think it's small, right? But it's not. Clinically, statistically, it's a huge thing because you can show almost an increase in 30 to 40% of your success rate just by using a checklist. Why do you think that is? You slow down and you think and you hit all those boxes before you commit and go down the road. I've seen people try to intubate people, no joke, I'm not going to say where or what the agency it was, but we went on a scene call. Traumatic amputations, we had a flailed chest, we had a pneumo. I mean, this lady had taken a UTV straight to the chest, essentially. Fatal with her husband, okay? But we got back, and the first thing we said, we assessed everything. Me and my partner were like, hey, we got to get going. She needs blood and trauma surgeon. We didn't carry blood at the time. So we just said, hey, we're going to make a run to the level 1. So he went back to get the aircraft ready, took the bags and everything out with him. I'm staying with the patient to get it unloaded. And next thing I hear is the automate's in. What part about we're going to leave and do all this and like we were going to do a finger thoracotomy, we were going to do everything in flight because we needed to get to the OR. That was the most important thing. Not me sitting on scene playing around. Let's go. And she was still, she had GCS about 7, so she was still there, but she was protecting her airway. Let's get her out and get going and do it. We communicated clinically. I thought we had a nice collaborative decision of, hey, we're going to go. And apparently someone didn't get the memo. Did you get the TPS report? No, you did not get that TPS report. So they gave the automatate, and I look up and I see the paramedic with a laryngoscope in one hand and a tube in the other. That's it. Not preloaded tube. I'm like, where's the bag? Where's your suction? Where's your O2 bottle? Non-existent. That turned into a Charlie Foxtrot really quick. So next thing we know, I'm opening up the side door, like yelling at my partner Aaron, hey, I'm doing this thing, like bring it back now. And we're having to do a battle axe over this lady, try to help this clinician get the tube because we're using our CMAC. You know, we're trying to get in there. We couldn't, it's in the back of a pickup truck because we were at the sand dune. So we couldn't get multiple providers around there and get access. But man, we had to make it work. And she survived, don't get me wrong, but goes back to, hey, think about what you're doing. That checklist is going to slow you down and make sure you hit all those points before you go down that path. You are clinically going to be more successful if you do that, okay? And we do have an example of our RSI checklist. If you guys ever need that to go to your department, just email us. We'll give you the Excel spreadsheet so you can make it your own. Put your own drug dosages on there. But I highly encourage it. We put on a little dry erase board. It's in our RSI bag. You take it out. You hand it to anybody, any Joe Schmo on the side of the road. Hey, can you do me a favor? Can you just start checking this off? Just yell it out. I'll just say check, 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 check. Suction on and out. Nope, it is now, okay? So once again, it helps you clinically. So if you hit an impasse or hit a roadblock, okay, you're prepared for that, okay? Okay, obstructions. Okay, there's been times where I go in and I'm thinking this is going to be an easy intubation. So I don't think anything's easy anymore. I treat all my tubes as a difficult airway because that way I never get surprised, right? So we go in, this lady has, wait, what? Where am I? Well, you know, I usually, I like Rich Levitan's little thing, epiglottiscopy, right? So I'm going to try to find the epiglottis. I know just beyond that is where I should be going. Go, tongue, inching down. Okay, there's the epiglottis, pick it up. I don't even know what I'm looking at. So that's where we went, cry. I said, cry. That was when my partner cried him. What was going on is she had a mass, a tumor that finally had 100% occluded over. You weren't getting anything through there. So once again, those obstructions. I didn't have the mind block because I was like, nope, don't see anything. A's down, B's down, we're going to C. So once again, if you have that kind of mental checklist and fortitude in the back of your head, hopefully you move through it a little bit quicker. So neck mobility issues, okay, pop the C-collar. Okay, if you've got a C-collar on, pop that sucker. Okay, think about people who have arthrosclerosis, you know, they can't move, getting old, they're kind of kyphotic. Trying to get them in a good neutral position as best you can. And that's also where laying them flat is probably not the best thing for them. We should probably set them up. What happens when you lay someone flat? What happens to your cardiac output? Goes down. What happens to your preload? Goes down. What happens to your functional residual capacity in your tidal volume? It goes down. Okay? We're taking all that away from a sick patient that needs every ounce of energy and treatments we can throw at them. So just think about that. Key with Heaven. Key Heaven, okay, this was developed by Dave Olvera in partnership with Air Methods. Okay, this is a good thing. He's a phenomenal clinician and a good friend. I love Dave. Okay, very smart guy. Okay, but the other thing is you think about it, this is more broken down, and I like it because he put it this is adaptable. It's Heaven this year. Okay, but you can start moving these around based on evidence. Okay, as more evidence comes out to support different clinical treatments, we can start adapting this to stay with us in the pre-hospital environment. But hypoxemia, okay. Any patient that's not sagging above what? What did Lindsay mention? What's our go-to? 94. Okay, anybody below 94 to 90, 90, 94, we should really start thinking, okay, if we can't get them above that, okay, that's going to be a difficult area. Why? Because we have a ventilation problem. We have an oxygenation problem, realistically. Okay, O2 sats less than 93. Extremes of sizes. Okay, we know that the more body mass index I have, the more O2 I'm going to burn, right? So you think about those people. They're also more difficult as far as adipose tissues, big necks, hard to get landmarks. So we know that these patients are going to be difficult. I try to get most of my bigger patients as far as ramping them up to 45 degrees. I like to come over the backside on top, especially like in the back of the ambulance skirting, right? I'm a taller guy, but if I widen my stance out, I can literally adjust my height based on where I put my legs and how much I spread out. And I'll just literally come over the side because now they're sitting up more. I don't have all that gravity. Women, okay, forearm strength becomes a little bit of a challenge. So use gravity as your friend to help you, assist you get that adipose tissue and that weight off of their neck. So that way you can more easily get in there. Okay, patients under 8, okay. Pediatric patients, how many here have tubed a pediatric patient? Okay, or neo. Okay, I used to fly neos for 2 years. We tube them. Extremely difficult. You're talking about, hey, we don't RSI them, so don't paralyze. They're breathing at 40, 60 a minute while you're trying to shoot this little target, right? So think about it. The smaller they are, they compensate less because they're going to run hard until they don't anymore. So that's also what catches us. So look for that train. Anatomic challenges. So, hey, am I not able to stiff neck? Am I not able to manipulate it, get that ear to sternal notch? Well, if I'm not able to do that, right there I already know my axes aren't going to line up very well. And so I really need to start thinking, what is my difficult airway kind of route? Okay, depending on what your program is, what your protocols might be, it might be different. We have what's called a hyperangulated or difficult airway blade. Okay, it's a little bit more hyperangulated. It's allowed me to get in a little bit more because I can't position the neck. Okay, but that is not going to function the same way as a regular Mac would. So you got to think about where are my limitations with going with that device. So is that going to solve my problem, or is that going to add to it potentially? So it depends on provider and, once again, training. Are you well trained on this piece of equipment? Vomit, blood, fluid in the airway, right? Is that going to be a challenge? Yeah, I got to get through that. So we talk about salad. We'll talk about James's salad technique. So exsanguination or anemia, I'm bleeding out. What happens if I have severe hemorrhage going on? What goes out with that? That we really need to get those little oxygen molecules. Hemoglobin, right? We lose hemoglobin. RBCs are going out. Well, the red stuff, well, that's where my hemoglobin is, right? I need those school buses to load up the hemoglobin to take them down the cell so I can help put my patient back into aerobic metabolism. So if I bleed out, well, I don't have enough school buses anymore. So I can't meet the demand. So what do you think the body's going to go into? What kind of metabolic process? Yeah, anaerobic. Okay, anaerobic metabolism, we start kicking out even more lactic acid, plus whatever else is going on. Okay, their respiratory rate's not there, not clearing the CO2, so you can see how that metabolic disarrangement can really go and swing rather quickly in some of these patients. Okay, neck mobility issues, once again, going back to I can't manipulate. Okay, so I can't manipulate C-collars, you know, are they on a backboard? You know, we're a big proponent of soft collar and sit them up a little bit, right? Okay, look at all the studies out there, and we just had a CME collective live cast on this. You look at all the studies out there, less than 3% were actually displaced, right? So we're doing C-collars for 3% of the trauma injuries that we treat throughout the entire study that they did. So it goes to show that really it's the worst thing. And then some of them, like if you guys heard the podcast, like Mike, when he teaches this class, he'll have everybody put a C-collar on. Put a C-collar on for 30 minutes and see how you feel. Think about laying on a backboard all strapped in for an hour. How many people have been on a backboard before? I've been on there. I've been flown twice now as a patient myself. And it's not comfortable. I remember when I turfed my bike and got road rash, you know what hurt the most? The pressure of the backboard on my back. That's what hurts the most. And I was like, I didn't know if I jacked up my back, but I had pain back here. Is it from the event or was it caused by the backboard? This one, in the case, was caused by the backboard. So you get pressure ulcers. Okay, question. You arrive at a facility for interfacility transport, okay, of a 34-year-old male in DKA who's obtunded. His ABGs is as follows. So let's do this. Okay, what metabolic disarrangement do we have? We have a pH of 7.19. What is that? Acidotic, right? So is it outside my normals? Yeah, it's outside normal. So I know right now it's uncompensated. So I give it a name. Hey, it's uncompensated. Uncompensated what? Acidosis. Okay, cool. Who's my problem? Who's traveling with me? Who's following me on this side of the fence? CO2 of 18, that's below 22, right? They're on the same side. Okay, so now I can call this an uncompensated metabolic acidosis. But what's the thing? I want to know if I have any compensatory mechanism. Is there anybody still fighting in this to try to keep these two knuckleheads from keeping going down that train? CO2 is 28. Where's 28? It's on the other side. So is this patient compensating? Yeah, so now it's a partially compensated metabolic acidosis. And that's important because if this wasn't, what does that tell me I probably need to start setting up on? Probably need to start setting up to maintain and help manage this airway. If not, I go, okay, he's compensating. Maybe if I help him out, get a little bit more CO2 off, make it easier to breathe with maybe BiPAP, give him a little pressure support to take the work of breathing off, maybe that saves off the intubation. Maybe it doesn't. But hey, it's a good trial, right? Least invasive, the most invasive. Okay, so PaO2 of 80, of these values, which is a clinical indicator to intubate, if you guys remember? A. Okay, so A, 7.19. So CO2 doesn't play in a factor. If I was talking about end tidal, what would the end tidal need to be? 55. What about the PaO2? 60. Okay, so these are, we try to drain these in and kind of ingrain these in a little bit, just because those are kind of checkpoints. If you see one of those numbers, you could really look at your patient clinically and go, hey, do I need to start going down that path, or am I able to stave it off using some sort of other adjunct? So A, if you guys answered it at home, good job.